Hello, I'm Dr. Ken Landau. Thanks for watching. Let's talk about pancreatic cancer. Cancer of the pancreas is increasing in incidence, but the survival statistics are dismal and they're unchanged over the past 40 years. 5-year survival is still only about 2 to 7%. It's the 12th most common cancer in the United States. For the average person, the lifetime risk is about 1.5%, 1 person in 67 going to develop this cancer. Even though it's the 12th most common cancer, it ranks 3rd for cancer-related deaths. It causes more cancer deaths than cancer of the breast. It overtook cancer of the breast in 2016 and is getting ready in the next several years to overtake cancer of the colon for the number 2 position. 53,000 people will develop the tumor each year here in the United States, 42,000 of them going to die. If we look worldwide, 460,000 people developed the tumor and 433,000 of those people died. So everything we don't want in the cancer, that's what we have in cancer of the pancreas, a lethal condition with a poor outcome and a rising incidence. And in spite of this, it takes a very long period of time for the cancer of the pancreas to get that way. It takes about 10 years from the time the mutations start to evolve until we get the cancer, and then another 10 years from the time we get the cancer until it grows significantly enough to cause its major mischief. But in spite of the long duration, we don't have any mechanism to make the diagnosis at an early time when the lesion is curable. Most of the time when the diagnosis is made, it's already an incurable disease. The incidence is highest in developed countries like in North America and in Western Europe. Most cancers are stabilized in incidence or decreasing, but not cancer of the pancreas. It's increasing at about 1% per year. In other words, in the past 40 years, it's increased by 40%. Lowest incidence in Africa and in South Central Asia. Risk factors we don't really know, unfortunately, because we can't do any legitimate studies because the disease is so far advanced by the time of diagnosis. Seems that age has something to do with it. It's rare in people less than 30. The overwhelming majority of cases, more than 90%, occur in people over age 55, with the peak being about 70, 71, 72 years of age. So somewhere in the range between 60 and 80, the elderly account for the greatest majority because of a lifetime of mutations that occur. It's more common slightly in men than it is in women. And interestingly, there's about a 70% increase among African Americans than there is in Caucasian Americans. Don't know the answer to why. Seems to be least common in Asian Americans and Pacific Islanders. Seems like your blood group might have something to do with it. Blood group O is the least associated with cancer of the pancreas. Blood group B has a 70% increase in the incidence, and certain gut microbes, the bacteria that live in your colon, might have something to do with it. There's a decrease in the number of strep mitis and an increase in porphyromonas and an increase in the granulocytella. Do they really have an incidence? We don't know. Their family history is very important as far as cancer of the pancreas. There seems to be an increase in genetic causes. So 5% to 10% seem to have a family history of the disease. If you have a family history, overall, your risk is 900% greater than it is if you don't have the family history. If one of your first-degree relatives has the disease, you have about a 6% risk. If 2 of your first-degree relatives have it, you have about a 10% risk. And if 3 of your first-order relatives have it, you have about a 40% increase in risk. And there are certain specific genes that seem to be mutated that cause an increase in the incidence. So you've all heard about the breast cancer gene, the BRCA2, BRCA1. They seem to be associated with cancer of the pancreas. And there's a gene that causes chronic pancreatitis and hereditary pancreatitis, and another one that causes familial non-polyposis cancer of the colon. All seem to be associated with this particular disease. Well, the pancreas can be divided into 2 different areas. Everyone knows about the insulin production. That's what we call the endocrine portion of the pancreas. Then we have the exocrine portion of the pancreas that makes the digestive juices. Well, we can have tumors in either area, but 95% of the tumors of the pancreas are in the exocrine area. And 80% of those tumors are the pancreatic ductal adenocarcinomas that we refer to when we just talk about pancreatic cancer. It seems like the diabetes is a risk factor. Diabetes is a risk factor. The longer you have the diabetes, perhaps the greater your risk, and especially in people who seem to develop their diabetes over age 50. Now the question is that they're developing diabetes just because they're developing diabetes, or are they developing the diabetes because the tumor is destroying the pancreas? Probably the latter. Modifiable risk factors, well, tobacco. The more you smoke, the longer you smoke, the greater your risk. If you're a current smoker and you've been smoking for a while, your risk is about 75% greater than it is for the average individual. If you're a former smoker, it's still elevated by about 20% until you've been off cigarettes for about 10 or 20 years. Drinking socially is okay. However, if you're a heavy drinker, that predisposes you to chronic pancreatitis. That's a major risk factor. So the incidence higher in men, especially who are drinking spirits. Obesity, especially central obesity, seems to be associated with the condition. Chronic pancreatitis, the progressive inflammatory condition, about 5% of the people going to develop cancer of the pancreas. That's about a 13-fold increase versus the general population. Diet, if it's got a lot of red meat, seems to be associated with an increased risk. And then there are certain bacteria that can increase the risk, maybe the Helicobacter or viruses like the hepatitis C. I'm not honestly sure about those. Well, by the time you present, the symptoms tend to be suggestive of far advanced disease. The symptoms early on are non-specific. You have some abdominal pain, maybe epigastric pain, pain in the middle of your gut, and sometimes it radiates to the back, or sometimes it's present just in the back alone, or sometimes a person just develops jaundice, yellowing of the skin that would be more common with gallstones or with hepatitis. Sometimes non-specific symptoms like fatigue or loss of appetite or unexplained weight loss or indigestion. And since the tumor can obstruct the area where the stomach leads into the small intestine, maybe you fill up easily or you become nauseated. And then some people, they just become anxious or depressed. Or we can have that new onset of the diabetes that develops in people over age 50. Symptoms, again, non-specific. Don't even have to be specifically related to the gut. Might complain of bloating or itching or shoulder pain or a change in your bowels. People who aren't making the enzymes that the pancreas makes under normal circumstances going to malabsorb fats. They're going to have a condition we call steatorrhea, where they're going to pass out a lot of oily, foul-smelling bowel movements. They're difficult to flush and voluminous. Well, the pancreas sits horizontally around where the stomach is. And the head of the pancreas on the right-hand side sits right where the stomach empties into the first part of the small intestine and can lead to obstruction on the body or the tail closer to the left-hand side. Then we have abdominal pain or back pain, or that's when the diabetes and the nausea tend to be more common. Tumors develop over many years, and they develop in a sequence, a stepwise mutation from normal to precursor lesions to localized growths, malignancy, and then finally to metastases. 60 to 70% of the time, it's the head of the pancreas that's the problem. 20% of the time, it's the midsection of the body of the pancreas. About 10% of the time, it is the pancreas tail on the far left that's home to the tumor. Well, there are certain precursor lesions, just like with cancer of the cervix, which is sort of an analogous situation, where we have certain abnormalities that at least we can see that develop slowly over a period of time. So too in cancer of the pancreas. We can have the pancreatic intraepithelial neoplasia. Well, that develops slowly, little mild abnormality, more severe abnormality, finally borderline right up against cancer, and then gets to be cancerous. Seems to progress over a period of about 10 years. We can have a cystic type in the ducts. That again progresses relatively slowly, but it's a relatively common condition, so we can't diagnose everybody who has a cyst and take the cysts out, that's about 10% of senior citizens. And most of these cysts are asymptomatic, relatively small. And then some women have a type of tumor that on biopsy actually looks kind of like ovarian cancer. When we study the genes specifically, we know certain genes are abnormal in cancer of the pancreas. So it starts off with an abnormality of an oncogene known as KRAS, K-R-A-S. And then a little bit later we have the P16 abnormality. Well, the KRAS is an oncogene. That's something that speeds up the cancer. Under normal circumstances, the P16 is a brake on the cancer, a tumor suppressor gene, anti-oncogene. So if we get the gene speeding it up and we take our foot off the brake pedal and then add a couple more genetic abnormalities in, you can see we have the potential for disaster. Now, there are lots of genetic abnormalities in cancer of the pancreas, so that when we look at just 24 different tumors, there are more than 1,300 abnormalities. Abnormalities that might be point mutations or variation in the copy number or structural realignment. And then on top of all of that, we have the epigenetic abnormalities and we have the translational problems. So very complicated area, but the most important thing to remember is that we have these early abnormalities, and it seems we have to be able to diagnose and to hopefully treat the lesion before it accumulates some of the other abnormalities that may or may not be important. They just develop. We want to make sure that the diagnosis is made with the important, what we call the founder mutations. Can we make the diagnosis on a blood test? No. We have several what we call biomarkers, the CA19, CA125, CEA. They're pretty worthless for making the diagnosis. Might be important to follow the tumor after treatment. Screening, unfortunately, isn't very good. We have the abdominal ultrasound that's operator dependent. The tumor has to be already pretty big to make the diagnosis. We have endoscopic ultrasound, we have the CAT scans and the MRIs and variations of the MRI, something called an MRCP or even a PET scan, but nothing to make the diagnosis at a relatively early stage. And part of the reason is because where the pancreas sits. It sits so close to major structures, so close to the superior mesenteric artery and the superior mesenteric vein that control the intestine, and the hepatic artery, and the portal vein, and the celiac plexus, and the liver, and the stomach. So that by the time of diagnosis, only 10 to 15% of the people have localized disease to the pancreas that can potentially be resected. They're potential candidates for surgery. Some of the people have what we call borderline resectable lesions. These are going to be difficult but not impossible to remove, maybe even if we treat them first with some chemotherapy. Chemotherapy before the surgery is called neoadjuvant chemotherapy. If we do that, then maybe we can transform some of the borderline into surgical candidates, but half of the people by the time of diagnosis already have metastases to the liver, to the lungs, or the peritoneal cavity, or to the lymph nodes. And we have to differentiate cancer of the pancreas that can have some of the same kind of symptoms as chronic pancreatitis. Well, part of the problem is that surgery has to be done in a major medical center. It shouldn't be done in most little local hospitals. You have to have at least 15 or 20 procedures a year in order to have the proficiency. And even then, the mortality rate might be less than 30%, but the morbidity rate, the complication rate of the surgery, is as high as 40%. 40% major kind of complications. So the question is, when we make the diagnosis, do we start with the chemotherapy and then proceed to surgery? Or do we start with the surgery and then proceed to the chemotherapy? And it's sort of debatable, but we can say that radiation therapy has a questionable role. In the United States, we're in favor of the radiation therapy and think it works. In Europe, they don't think it provides much benefit. Well, certainly, when we're looking at people who might be surgical candidates, if the person has cancer cachexia, has lost a lot of weight, seems to be malnourished, loss of lean body mass or muscle atrophy, or impaired function or decreased liver production of important substances like albumin, then that person's not a surgical candidate. And remember, only 10 to 15% of them are surgical candidates. And then we have to say, if the person has surgery, there's a high likelihood that there are actually going to be micrometastases, little tiny areas of involvement that we haven't been able to see, or that really approach the surgical margin. And surgery is a major hassle, so we have to decide whether surgery is the answer. If we do surgery for the tumors in the head of the pancreas, where it tends to begin, we have to remove the duodenum, part of the jejunum, another part of the small intestine, often remove some of the stomach, all of the stomach, and then remove the gallbladder. Major procedure. That's why it should be done in a hospital that does a lot of them. And even after curative surgery, even after we think we've cured the person, the likelihood of survival at 10 years is only 4%. And remember, that's in the 20% of the people, or the 10 or 15% rather, who are surgical candidates. Now, if we only do the surgery, survival is going to be about 6 months. But maybe if we do the surgery and we use some chemotherapy even before the surgery, well, we might improve the survival up to a year and a half. And then the question is, what kind of chemotherapy? And that's evolved over the period of the past several years to a point now where the most popular mix of chemotherapies for cancer of the pancreas is known as FOLFIRINOX. This just initials, and it stands for folinic acid and fluorouracil and irinotecan and oxaliplatin. And now that's even been modified to cut down the dose of the 5-fluorouracil so that the people don't have as much toxicity, especially on the blood marrow toxicity. But even so, if we look at the survival in those people who can undergo surgery and who have the therapy, the disease-free survival is about 22 months versus 13 months if they don't get the therapy. If we look at the survival at 3 years in the 10 or 15% of the people who can have the surgery, it might be as high as 40% versus 20% of the people who don't get the therapy. And then there are modifications of that therapy, but there are a lot of complications. A lot of complications that people get that have to be treated somehow, and it might be obstruction when the person develops jaundice, or prevention of emptying of the stomach into the duodenum because of the tumor mass. Or these people oftentimes have very severe pain that's not readily taken care of. And even at best, we have a major disaster, at least as far as the therapy is concerned, as far as the survival is concerned. So overall, remember I said 4 to 7%, 5-year survival. The chance of surviving 10 years is about 1%. And these numbers have really been unchanged over the past 40 years. And even if we have successful resection, and even if we use the chemotherapy and everything is going well on that 10 or 15% of the people in whom the surgery can be performed, the 5-year survival rate is only about 25%. And if it's locally advanced disease, it's only likely that you'll survive 6 months to a year. And if it's metastatic disease, the survival rate, well, 2 to 6 months is the amount of time. Why do people die from cancer of the pancreas? Well, they die because of extensive metastases in 70% of the cases, and 30% of the cases because of limited but bulky metastases that take up all of the nutrition from the body and then cause a person to lose weight, even though they're eating, although typically they've lost their appetite. But even if they could get the calories in, the calories go to the tumor. They don't go to the person. So unfortunately, there you have it. We have a bad disease, and it seems like the likelihood of significant improvement in the near future is kind of iffy. We have a tumor that's rising in incidence. It's now the number 3rd cause of death, soon to become the number 2 cause of death among cancers here in the United States. All we know is it tends to congregate in families, and you can tick it off by drinking too much alcohol or smoking too many cigarettes. But aside from that, there's not all that much it appears that you can do. You could watch your diet, perhaps, but at least at the present time, we don't have any mechanism to diagnose it at an early stage. So hopefully, we're going to have some genetic analyses in the near future that can at least give us a hint as to who most is likely to have the disease, and maybe we'll have some kind of a test so that hopefully we can make the diagnosis at an earlier stage. Anyway, thanks for watching. I'm Dr. Ken Landau.